Well, I'm Dr. Tom Told. I've actually been a a Colorado physician for more than 40 years. As in fact, this is the only place. Colorado is the only place I practiced. Even though, well, I do have a Wyoming license, and I did practice in Baggs, Wyoming. As the physician there for about 28 years until I came down to Rocky Vista to be a start off as a rural health. I was going to start a rural health program, for Rocky Vista University, which was founded in 2006 and took its first class in 2008. So I was involved with the founding of that school, primarily with a rural focus, and that was how I got involved in that. Had been involved with the Health One residency programs for since the 90s, and had been in physician education. Had also been the national president of the Osteopathic Family Physicians, in the early 90s, and was its president in 2006. I think, yeah, 2006. I was the 6-7. I was the national president. So I've been involved with student education, visited all the osteopathic schools. So I kind of got the bug for education, and left my practice of 35 years and came down to the university to start that rural program. It was very successful. We now have a rural track, and through that I was sort of promoted up the line, and in 2013, my longtime friend and classmate from Kirksville, Bruce Dubin, left to go to Kansas City, and I assumed the interim dean's job for a year, and then became the dean of the school, and later the vice president for academic affairs and dean. Uh, I was born and raised in Utah, and so I realized that Utah needed a osteopathic school, so I was instrumental in starting our branch campus. It's actually an additional location down in Ivins, Utah, which is St. George, southwestern Utah, and it presently takes 135 students a year as well. So now I'm the dean over both campuses, and and again, Utah has a lot of rural sites, and so we've been able to go ahead and establish a rural emphasis over there. Primary care emphasis is what we're up to. As you know, osteopathic schools put more of their classes proportionately into primary care, and I really wanted to inspire our students to go on the rural side of things, because honestly, it's still the very best place in the world to practice, is out in the rural communities. Challenges, but we want to produce medical students with the confidence and the toolbox full of skills that they can go out there and not be intimidated, and so forth. So that's what I've been spending most of my time on.
I can't help but play just a little bit of I told you two degrees of separation.
Yeah.
I came to Colorado the last time. I started out in the National Service Corps in Yuma, which is in the northeast corner, and I've been affiliated with that part of the state ever since. And then, but when I came back, I was at the residency, on the faculty of the residency in Greeley, North Carolina Family Medicine.
Right.
And, I'm the person who put together the rural training track there, which after Spokane was the first one in the country, and it's still going in Ray.
Oh yeah.
And one of my very first advisees was David Reed from Baggs, Wyoming, whose dad was the basketball coach there, and he's still practicing in Ray.
And my patients.
Oh, really? Okay.
Yeah.
So we both have stories to tell about David when he was a wee one.
Yes. Yeah, I knew David and his wife. They're high school sweethearts. That was it was, who would have thought the kids that got married in high school could make it all the way through medical school?
I know.
It has to be, one of those Herculean stories. Yeah, that's right.
Yeah. I know, it works out sometimes, doesn't it?
Yes, it does. Yeah, Dave's a great guy, and actually epitomizes what we want to do. Full scope family medicine. Out in I did everything, delivered a ton of babies, did a lot of, all of those things, and that's essentially what we need now for rural areas. Is not 14 specialists that fly out once a month. You need a guy that can go ahead and take care of the things that happen every day out there, and that's what we're trying to foster at Rocky Vista. Is
Well,
that
when I was in Yuma, where there was one other doctor in town, and then I brought a partner who was a nurse practitioner, which was the first of those they'd ever had. I mean, that was it, and we did everything.
Yeah.
And now in Yuma, they have ER docs. I don't know if they have hospitalists. They do in Brush, where I used to practice.
Mm-hmm.
So rural practice has certainly changed a whole lot.
Right.
In many places, but I agree with you. I think it's just a terrific job. If you can.
Yeah, it's my son, he practices in Idaho just because he got a nice place up there. He's the chief medical officer, but it's run totally by family docs. They're not cowboys. They
Yeah.
practice within their scope, but they still go ahead and do deliveries and, some surgery and, their C-sections, the whole works. And the town just thrives. They went to that model, and this hospital was struggling, and then all of a sudden it's like Yuma, boom, you're up. You've got all these services going, so the embellishment of primary care, I think, in the rural areas is the tonic that's going to go ahead and revive some of them that are kind of on the rocks.
I mean, frankly, I think that's true of the whole system. That
Yeah.
is of late coming to understand how important we are, and much more important, of course, from my biased point of view, than the high yield specialties, the high
Exactly.
yield procedures.
Well,
They had to do to survive.
exactly. And that's what I tell everybody. The more you specialize, the bigger city you have to live in and the fewer people you see. And what we need to do is the more you generalize, the smaller city you can live in and the more people you can see. And it just seems like we're going in the wrong direction where we put our money sometimes,
Well, I think all bets are off right now about what the system's going to look like in a year or two.
Yeah.
So,
oh yeah. Go ahead.
Well, so to get to the kind of the meat of this, and it's a discussion. I know I sent you a list of possible questions, and it's only to give you an idea of the ballpark of things we might talk about. But I never even look at it. As we learned in training, you ask open-ended questions and you listen for the answers, and that's how you get the best information. So this is a conversation. I don't have a checklist here. I don't have an electronic medical record. So I'll ask you, how has COVID affected you, your students, your colleagues, and your professional life? Like, what's it been like during this time?
Mm-hmm. Well, actually, there's a couple of levels to that. Obviously, as a medical educator, it caused us to take a really strong look at our curriculum and, what was necessary, what was not necessary, and, switch it to a virtual platform. One of the first things that became evident to us was that there was no way that we could do the human interaction part of our curriculum. That is physical exams, patient interactions, and then being DOs and osteopaths, there was no way that we could teach the manipulative therapy, because that is about as close as you can get to your patient sometimes as possible. So
I've had an osteopath wrapped around me.
So if you're in the Kirksville Crunch, that's the bear hug. That's probably the last thing to go in this COVID. As we come out of COVID, is this, the bear hugs type that we get. I guess that's why some of those, some of those venues like weddings and so forth are so high risk. But anyway, so we've gone ahead and done that. So we did morph really well, and we were able to really turn this around. Let's see, probably within 2 or 3 days, we were up and doing virtual. And then that was probably one of the first challenges. The other was, how are we going to go ahead and deliver clinical education in a environment where everybody was locked down. In other words, the hospital locked out virtually every type of student, healthcare student. So we had to go ahead, and luckily we were in a position where we were able to have, we had accelerated our students getting their cores in so that they could have a little bit more time to study for boards. And so we only had maybe 6 students that were sort of in arrears, when the hospital shut down. So those, we were able to go ahead and do that. That was, so that particular part, it's been a challenge. How do we go ahead and develop the PPE? How do we go ahead and run our operation virtually? So Rocky Vista, really, I can say we didn't miss too many steps, and we were up and running. Excuse me, we were up and running, within a week afterwards. Excuse me.
Sure.
And so that was that particular part. The other part was finding out what we had to do to backfill a curriculum that is totally virtual. And we had talked about that, and how do we go ahead? Do we we get virtual reality experiences for the students, a few things like that, social distancing. So that was our biggest challenge. The second part was that we have a lot of retired physicians in our workforce. So we had high risk people in this environment as well, many of them in the leadership positions. And so, in-person meetings had to go. We ended up having to teach people that had never, that were more face-to-face people, virtual stuff. So there was, there was a lot of work went into backfilling, getting people up to speed in order to have meetings like this, to feel comfortable, on a virtual platform. So that was it. Personally, I came from Northwest Colorado, who everybody felt that COVID was a conspiracy. Nobody wore their masks, So, being 77 years old with, hypertension, I needed to, be a little bit more careful, the same way, we had some chronic conditions that, made me a little bit more careful of, how to go about it. So that, we had to alter our lives, had to be a little less outgoing than what we were. It certainly curtailed our air travel. I would probably go to Chicago at least once a month. We were all over the country, and I've not been on an airplane since March. So, and I, doing a lot of this, and I've been involved in a lot of national things that we've switched to a virtual platform. So that's part of it. I think now the challenge we have is, will people come back to work? What about the people? Are we gonna be able to get them off a virtual platform and maybe into a little bit more face-to-face as we come into the various phases of emerging from this this particular challenge. Yeah.
Can you go back to talking about the adjustments you made in the training? Give me some examples of aside from conferencing, or of other sorts of adjustments you could make in the curriculum or in how you taught.
Right.
Like you mentioned, for example, virtual reality, which is really interesting. But
yeah.
Most anything that you.
Yeah. So we did do virtual reality, primarily the interface with standardized patients. professional patients. They were, of course, concerned. The virtual, the standardized patients were concerned about face-to-face with students, particularly medical students. So what we did is we looked for a platform that had patient interaction virtual reality. We had hyper-realistic simulation in our school and had like surgery prep courses, where we would use a hyper-realistic dummy. It's a 30-pound torso that you can put on somebody that's anatomically correct. We have computer 3D printed organs inside. It bleeds. You can go ahead and do surgery on it. You can put chest tubes and things of that sort. We had a prep course for surgery and also for obstetrics, where we had people get together. We had to go look for virtual reality platforms that could go ahead and teach, surgical technique or do hyper-realistic simulation. Now we're down to where we do those, those platforms with full PPE and instructors. We went back to that, especially as we get back into, the hospitals again. So we had kind of toyed with virtual reality, but all of a sudden COVID put us right face to face with, it was either that or nothing. And so that's why we, went to that platform, and it was a good bridge into, what we had been doing before. So that's what we sort of bought time with the virtual reality. Now what we'll do is we'll go back to a platform where we do it, with PPE, same way with OMT, but we can utilize some of those virtual reality platforms to prepare the students for perhaps a shorter session, because you can't spend all day, with one group of students, or you can't have 100 students in a big area. So what we do is we concentrate it with a prep using virtual reality, and then a real-time experience with instructors, in PPE.
You were able to scale it up that fast?
Yeah, I was. We were earlier. Let's see. I guess 3 or 4 years ago, we were certified by the American College of Surgeons as a simulation center. We kind of worked in that direction, and it sort of fell around our acquisition of the cut suit. The cut suit was used by the military. We had a former military surgeon who joined us, Anthony Laporta, who had been involved with that, and strategic operations got involved as a beta test site for the cut suit. So we had gotten accreditation by the American College of Surgeons as a simulation site. So we were sort of working in that direction. We didn't start right from ground zero, but we had a lot of experience up to the time of March of this year, on hyper-realistic simulations. So it was a natural transition for us. We'd bought a 3D printer to print some of the organs to help strategic ops. We were partnering on some of their innovations to make. So we were trying to come up with ways to make omentum feel like omentum, and how to sew blood vessels, and what type of materials you could use to make it more hyper realistic. And our goal was not just to teach medical students, but maybe to get up and supplement surgical training for many of the surgical residents that have never done an open case. They had all done laparoscopic stuff. None of them have ever opened up the abdomen. Only the trauma side of things opened up the abdomen. So what we wanted to do was to make, something that was safe, that would feel like it, that would bleed like it. So we had ruptured livers, and we had tumors, and we had all of these things that we were, incorporating into the intestine and into the belly, that would bleed and feel and do everything. And then, we could train some of these residents on how to do an open procedure, because
that's you're making me feel old when you talk about general surgery residents who've not done an open case.
can you believe that? I and you know, had I have not experienced this at all, Mark, I wouldn't have I wouldn't have believed it either. I
I
mean, you know,
know.
that everybody does everything with a laparoscope now.
You know,
Even chest surgery now, they're doing, you know, everything through endoscopic. And you know what happens if you don't have an endoscope, or you know,
well,
yeah,
it
yeah.
used to age me when I would, encounter medical students, young doctors, residents who'd never seen measles. That was another thing that,
Oh yeah, exactly. Well, you know, I went in the I came from Kirksville, and I'd had more of a generalist education. And when I did my internship at Fort Sam Houston, yeah, we had a case of chickenpox, and half of my intern class had never seen a
I
case
had
of
no idea,
chicken.
I didn't know what it was. I've got
Yeah,
a
it
scar right
didn't
here on my forehead.
yeah, yeah, me too. I bear a few scars as well. Yeah.
um, so how successful would you say is this? How effective is this virtual reality training?
Well, you know, the virtual reality side of things is new for us, but what it did was, you know, it certainly doesn't beat. You know, that's what we found.
Right.
There's nothing virtually you cannot reproduce in real time the actual touching a patient. That, you
Right.
know, that's what
Right.
we yearn for. But I think what it does is it allows the it starts building confidence that students know where to start. You know, how do we teach? You can't teach palpation skills. You can teach where to palpate, but you can't teach those nuances.
Right.
Uh, you know, and in fact, when we get back to this, what we want to do is to maybe make a suit where you can have a rigid belly, and you can have a mass, and you can have, you know,
Mhm.
or something like that, where you can do that. Maybe sometime you could have a model at home where you know, you could maybe go ahead and reproduce that electronically. But you know, that was one of the things that we really felt was our limiting factor. That was the one thing we learned from COVID, is that you're not going to be able to reproduce the tactile sense
Yeah.
necessary to develop those skills. You know, that's for sure.
And I think that the technology is still a long way from being able to do that haptic
Yeah.
feedback well.
Yes. Yeah, I think so. And even as good as we are, you know, I think we are getting better. You know, to do the you know, our hyper-realistic simulation. And in fact, you know, we work with EMTs, and we can make enough injuries on the cut suit to where those guys are actually visibly sweating by the time they
Yeah.
get through that, you know, and you can actually overwhelm them to where they can't pack the wounds, and they can't stop the bleeding, and all of those things. Those things are great, you know, to learn on those, rather than a person who's paying the ultimate price, you know.
And I assume that your classes with conferencing, there's really not that much difference.
No,
Um, not being able to do them face to face.
you're right. Yeah, and that, you know, that is, it's nothing really beats face to face human interaction. And I think that's one of the biggest things. And people crave. Now we're coming back to work, you know, we're redoing it, and some people just come to work, and the first thing they say is, it's great to see you in person. You
Yeah.
know, I think that, you know, and I think that's you know, what a doctor actually needs. And I still worry about telemedicine taking some of the humanism and some of that, you know, what we call the sixth sense, or the fifth sense, or
Hmm.
whatever it would be, you know, that feeling, that clinical impression you get from the way that a person stands or acts, and you just don't get that on a telemedicine screen, you know, that way.
I agree with that. Although I think that here I'm editorializing. I think that the template checklists on EMRs are these days a bigger barrier than meeting patients on the screen.
Absolutely. Absolutely. Copic sure agrees with you that, you know, that you just, and they can hurt you too.
Hmm.
you know, that you just got to be careful what box you check, because you could be held, you know, whatever. You got to read the whole thing, what you just checked off. And a lot of people just check, and it becomes, well, you didn't check those things. You know, did
Yeah.
you do all of what it was said in that line? You know, so
Yeah.
yeah, there are new perils that go along with digital medicine for sure.
Or what text you've imported.
Yes, yes, yeah.
Yeah, that gets people in trouble a lot. So during this time, have you had, was there any pause in having students out at rotations in the communities?
Yes, at first, you know, there was a little bit of, I think where we ran into some issues where we had students that, you know, students being students, by golly, you know, they were ready to roll into the hospitals. You know, we had New York, for example, licensing our, you know, our graduates early. You know, going ahead. We actually graduated our students early. We had them ready for graduation right up. So we had our students graduate on the 1st of May.
Mhm.
Some schools had graduated students, you know, even in April. You know, they had
Mhm.
to go ahead and tend to these. There was I think the angst on my part was that sure we could graduate them, but the state medical boards were saying, look, they've got to complete their course. We're not going to give them a license if we don't do that. And there was a lot of angst about, I don't want to graduate my students and they can't get a job, or they get in trouble with the medical board. So that was probably some of our biggest concern, you know, around that. You
And is
know,
that straightened out?
yeah, it seemed to. You know, I think the ACGME and the Federation of State Licensure Boards were totally at odds with New York. But I think that what happened was everybody finally got together and came up with a compromise. You know, we still are not sure, you know, what happens if we have a second wave and we have to have a second lockdown. You know, we're committed to graduating our students on time. How are we going to go ahead and make for some of those requirements that are needed, you know, at the hospitals? Luckily, I think today, as we sit here today, a lot of the hospitals understand what the issues are, and we're going to go ahead and bring our students back. But back to your original question, you know, I think the students were wanting to go out. They were chomping at the bit. Let us go out, carry the banner. Let you know, we'll sacrifice ourselves to do that. And so they were saying, yes, we want to go. We were saying, we can't put our students in harm's way. You know, they don't,
Mhm.
they shouldn't be involved with COVID patients. So there was a little bit of tension between administration and students. Students felt that we were moving too slow. We didn't want to put them into a unsafe environment. We didn't want to mandate that students, you know, go into a COVID environment. So, you know, for a while, I think that was through April and May, there was a lot of tension, I think, between the student body and, you know, and a lot of the administrations of medical schools. And then there was this issue of the accreditors hadn't really caught up with what are we going to allow you to, you know, forego. For example, we have a requirement that students all rotate in a hospital situation with a resident. Well, all of the residencies were closed down to anybody but residents, you know, and even their rotations were curtailed. So how can you really go ahead and make that requirement where every hospital in the United States had locked down their residency programs and kept them all in house and had no visiting students or other residents? So that was a challenge.
How did you get around that?
Well, they actually furloughed that requirement. You know, they actually said, well, we can go ahead and do it. Luckily, we had, because we are involved with a residency program at Skyridge, many of our students had already gone ahead and rotated with a resident, you know, at
Mm.
least in one of the programs that had a residency based with it. So we were pretty lucky. But going forward, if that ever happened again, and we had not had that opportunity to be in a pre-COVID environment, I think that would be a challenge. How are we going to go ahead and do that? Luckily, we're better prepared than we were, the first time around now. So a lot of hospitals are allowing us to provide at least pay for the PPE extra that they have to do and allowing them back into the hospital. So I hope going forward, that's not going to be a big issue,
What a challenge.
Yeah. Uh, a lot of, there's been extra expense that's involved. We have to pay for PPE. We go ahead and help the hospitals with the extra expense of training students,
And so how is the school doing as an institution? Just are you still whole financially? Are you?
Oh yeah, yeah, we're good, and a lot of the students, I think there was a national movement on the part of the students that said, well, if we can't go to the hospitals, if we can't go to the clinics, and we're just studying from home, this is online education. It should be cheaper. We want a refund. So what we did is we called our students together and said, well, that's fine. We can give you a small refund, but look at what we're saying to the licensing institutions. We're saying that you didn't get an education, so that you didn't get an adequate education, so we're refunding you. So they're going to say to you, how are you going to make that up? We give you a refund. We're essentially saying that you got to go a little bit longer, even if it's for free, to make that up. So, I think that what you need to do is bear with us, and I told my students, if you can't learn to work with adversity, you're not going to be able to work at all. And that's, medicine is working with adversity every day. So, after a while, I think the students got around. We didn't raise our tuition, we didn't do a lot of things, but we had it. But the institution of virtual reality and extra funds for PPE to get students into hospitals and all of these other modifications pretty well ate up everything in the tuition that we needed to do. And and then we were trying to keep tuition level as much as possible.
Do you have any students currently in rural practices?
Yes, yeah, we do.
And that's going okay?
Yeah, that's gone great. In fact, the rural side of things has been, probably the more stable side. We've got, we have, especially in Utah, we've got all of the rural practices in Utah, eastern Utah, southern and eastern and southwestern Utah. So yeah, they've been doing very well. In fact, probably the biggest challenge has been the hospitals and hospital based physicians having to be bound by the hospital rules to not take students.
Right.
The other docs are perfectly fine.
Good. So your students have been able to go out and get good experiences.
Right. In fact, thank goodness for the rural areas. They were able to, not really interrupt once we were out of that national lockdown to where we could sort of integrate students back into practices. It was the rural programs that sort of led the way. And the benefit, I have to tell you, as an educator, the benefit of a rural program is you can make it longitudinal. I don't necessarily have to have I don't have to compartmentalize my education, to do that. I can send them out to a little area, and I know they'll get some emergency medicine. They might deliver a baby. They might do a little bit of, surgery because they didn't get all this elective procedures locked down. That was what really killed us, was the locking down of elective procedures, because that left the subspecialty side completely, devoid of the ability to, deliver an education program.
Mm-hmm. Have you had any students who have run from things just out of fear? in this
Oh, you
environment?
mean for the most part, no, that hasn't been a problem. We did give some students the ability to opt out right early on when it was, when the fury of the disease was, and the uncertainty. We had some students that wrote in and said, "Look, I would, I would prefer not to volunteer." So what we did is we made, going back into the hospital during those times
Mhm.
voluntary, and if somebody felt uncomfortable, then we put them on some other safer or virtual program so they didn't have to really, expose themselves. And they would be students who lived at home, maybe with, with an immunocompromised parent or, sibling or something like that. Those we were sensitive about, not having them go into the, go out on those types of rotations.
And have you been able to lift that option now?
Yes, yeah, in fact, we had our clinical, we're going to put our students back into, the third year, the new third year. We're going to put them into their course on August 3rd.
Mhm.
So they've been, one of the side effects of this is these kids being locked up in and having to study all the time. Our board pass rates are great. you know,
Yeah, that
they
must be
finally
really
got
good.
what they wanted. We
Uh-huh.
kept reminding them that you always wanted extra time to study for boards. We've come up with it. You've got we tried to de debulk the curriculum so that you could you could do well that way.
Between binge watching Netflix.
Yes, yeah,
Yeah.
yeah. That is the problem, or video games or something like that. Yeah.
Um, I just wanted to share with you a quip that I read. This was a while ago, and it was about mask wearing and social distancing and stuff. And it said, "Think twice about this." This was in the spring. It said, "Think twice about this. You don't want to get sick in July and go to a hospital where you have a brand new intern who spent their last semester learning virtually."
Yeah. Yeah, I think there was a lot of angst on the part of these students to be called COVID docs,
Yeah.
and how are we gonna, and I'm sure you're right. When you talk about this, people are gonna research these docs for a
Oh,
long
absolutely.
time, as to how they, how they're gonna go ahead and morph into that. I really do believe that they'll catch up really
Oh,
fast.
yeah. I
You
think that if there's harm done by this, it'll have more to do with kind of a tentativeness. Um, it won't have to do with what they know, because
know,
we don't. You're never a finished product. And I did a lot of CME like you too. Uh, you know, uh, Worked in that and consulting and stuff. And
I,
we know
I
that.
kind of like to think of them like preemies. Preemies get born low birth weight, but
Yeah.
wham! I've got some of my preemies I delivered that were like, 2,000 grams, things of that sort. Now are like
Yeah.
6'8",
Right.
deputy sheriffs, all of that. So I think that this adaptability of the body is
Absolutely.
incredible.
Yeah, these are just fascinating times to be living in, and I think the people who come after us will look back at this as this is when the world changed. How it will have changed, we don't
Yeah.
know, but yeah, I agree.
Well,
In
it's
medicine
it's
too.
certainly, everybody had toyed with curricular change, but what it did is it just slammed it right in our face, and it was kind of a educational Pearl Harbor of sorts.
Yeah.
Where we ended up
Okay.
having to make do with what we had. Don't you
What,
think so?
so, what do you think the long-term changes, curricular changes, are going to be, or training changes are going to be? Um, Hi.
uh, you know, like uh, you know, a little more time to, the physical exam skills, palpation, some of those things that we're going to do. Obviously, we're going to be able to supplement a lot of the lectures. We're probably going to go to more small groups. I think that will facilitate, team-based learning, small group learning. Probably use of virtual reality will come into play, not necessarily as a way to teach, but as a supplemental to some of those physical exam skills, so that we don't have to, so that they'll come a little bit prepared. Maybe didactic sessions will get shorter. We'll probably, go ahead and try to have more, on hands-on experiences that are a little more concentrated than what they were. That way, I think primarily facilitated with, with these other modalities, that we can make them more effective. Yeah.
I'm all for that.
Yeah, me too.
Always have been. Lectures are we both know, are about the worst way to learn.
Yeah, I know it. That, what is it, 15 minutes, and then the attention span goes to watching YouTube and getting on Facebook while the lecture's going on. As a dean, I used to walk in the back of the school and see how many people were tuned into the lecture. I'd walk into the back of the lecture, you could see everybody's computer screen up there and see how many Facebooks were up and how many had social media and other things. We're looking through through Amazon and a few things that way. Yeah.
So, it seems to me, obviously, you're very engaged in what you're doing. And how has this been for you personally? Would you say that your stress level has, by what percent has your stress level increased, or has it really stayed the same?
Stayed about the same. I get a little more sleep than what I did. I used to have to go in. I would usually be at my desk at 7 every morning. I now sleep to about 6:30 instead of having to get up at 4:30 and 5. And the reason why I'd have to go in is I didn't have any free time. It would be, I'd have to get there between 7 and 9, because at 9 I had a steady stream of people into my office. So in a way, it's been a little bit less stressful, because I've got a little bit more time, to think about that. Certainly have enjoyed, the downtime, at home, a bit more. But I do miss, this interaction with faculty. And I think they, we used to solve it. It's amazing how many problems you used to solve, at lunch or over the, at the water fountain, or, just while you were standing out at your desk. The intelligence that you would learn about the running of the school,
right,
that way is what I miss a lot. And I think that's it. So it's good. And being an old guy, it's nice to get the extra sleep, because I think sometimes I would you only get 4 to 5 hours, and that in a COVID environment with my age might have been a little bit of a risk factor.
It's always nice to get the extra sleep.
Yes, I'll say.
And good for you.
Yeah.
And how's morale? The faculty morale is okay?
Yes. Yeah. We've scheduled regular town hall meetings. We do have a COVID response team that keeps up on the latest, the latest developments, and in both, not only the school, but nationally and statewide, both in Utah and Colorado. And we have regular check-ins with the faculty. And I think that they feel in touch. We've beefed up our mental health services a bit. Both for students and faculty have had, and that's, having said that, that's one thing that we were sort of surprised with, is that people actually felt that the virtual platform was maybe a little bit more comfortable for them if they had mental health issues, to sit down and talk. Right. And we'd had telepsychiatry for a long time, and so maybe that's better. Maybe some people get quite as intimidated to be honest, in
It's
this
true.
particular, uh, media, that way.
Has there been a much of a boost in clientele in business for the counseling services?
Oh, you mean for counseling? Yeah, probably about 20% more
Okay.
than what it was. And I think the biggest problem were faculty and staff that ended up with a whole house full of kids and ended up having to try to balance them out. I think that was where a lot of the flash came.
Mhm.
If they were juggling two hats, I think they were the ones that were probably most stressed when we were
Mhm.
in the throes of a complete lockdown.
Okay. Um, well, so is there something more that we haven't talked about that you'd like to say, or any sort of messages for the future about what it's like now and what there is to learn from it and where we're going?
Right, right. No, I think your conversational part is drawn out a lot of the issues that I have. Uh, I think that this uh, this experience, honestly, has only fortified my impression that training medical students as broad as we possibly can is training them to be able to not decompensate when they run into issues and unexpected changes is probably one of the most important things that a medical school can do. Focusing on those physician traits and adaptability is probably one of the key things that we need to really teach. If nothing else, this Gen Z generation, that has sort of had people intervene for them. I think that's one of the more important things that's gonna come out of this particular environment, is to see that they'll look back on this and say, look, I made it through that time just fine. This particular problem is kind of pale in comparison to that. So, I think that's going to be one of the great things that comes out of this.
You just raised another issue. I thought we were about to wrap up, but
Yeah.
how do you teach resilience aside from just by example when adversity comes your way? Is there a way you can put that into the curriculum? Have you thought about that?
Yeah, well, obviously, getting a lot of material fast, kind of teaches them resilience. I think what you have to do is it's reinforcement, of this when problems come about. I think it comes up with a lot of group interaction, small group interaction, discussions,
Mhm.
peer mentoring. Yeah, you're right. I think that's essentially how you have to really go about it. I put things on the log about some of the adversities that I've run into, and how, and I don't know, maybe you need to highlight some of those students that they're able to do it. Uh, I think it's just a matter, and then maybe it's hyper realistic simulation. That's what we were doing to get them into a situation
Get them
where they're sweating.
sweating.
Yeah, where they're sweating, and nobody dies.
Yeah,
That's I think we need to come up with scenarios that are that way. Yes, that's how you teach resilience.
yeah.
You know.
It comes down as teachers or as physicians. It's still the most important thing is who we are as people.
Yes, yeah, really it is, and how you don't get so focused on the little things that that you're overcome by the big that you should have
Yeah.
really been looking at. Yeah. No,
Well,
that's a great question, and we're still working on that. With this hyper realistic to try to make situations as realistic as possible. Looking at the airline industry, you
yeah.
know, how do we, you got to get them into a situation where the plane's going to crash, and you have you have the stick. You've got to go ahead and pull it out. That way.
And sooner or later, that's going to be part of certification and recertification. But we have to get much better at the human simulation. An airplane's, I don't know how many millions of working parts, but it's still way less than a human
Still
being.
a rudimentary machine compared
That's
to the
right.
human body, that's for
Yeah.
sure. Yeah.
Well, thank you so much, Tom. And,
thank you, Mark. It's been a pleasure.